Hello everybody, it's Dr. Ryan here again. Today we're tackling quite a vast topic, looking at the tongue in systemic disease. As always, a clinical case. We have a 58-year-old man today who comes to your clinic for a routine physical examination. Now he has a history of hyperlipidemia and hypertension controlled with atorvastatin and enalapril. Now despite regular counseling, he smokes 1 pack of cigarettes per day. On physical exam, he noticed some ulcerations in the mouth below the tongue. The lesion is not painful, that's a big clue, and the patient reports no recent mouth symptoms. Which of the following is most likely diagnosis? So we can see it's actually 2 lesions depicted here, 1 here and 1 here. Is it an aphthous ulcer? Is it Behçet disease, herpes virus type 1 infection, HIV infection, or oral leukoplakia? Okay guys, when you're looking at the tongue on physical examination, what are the possible diagnoses that one may make? The first question, is the tongue dry or moist? Right, this is an important sign picked up by physicians in the days of old. They say, if they're looking at the general condition of a person, they'll say, stick out your tongue, let me see your tongue. So is the tongue dry or moist? So if it's dry, it could indicate dehydration or mouth breathing, or this could be Sjogren's syndrome with xerostomia. It could also indicate anticholinergic drug therapy, which dries you out, okay? It dries up your secretions. If the tongue is moist, it could be a situation of sialorrhea. In post-encephalitis patients, it could indicate Parkinsonism, but you look obviously for the other stigmata of Parkinsonism, like the hypomemic facies, the glabellar tap will be positive. When you look at the gait, it's a typical Parkinsonian gait with freezing and festination, etc. If the tongue is moist, it could indicate local mouth infection, gastroesophageal reflux disease, or even heavy metal poisoning. Watch out for the blue gums, which accompany lead poisoning, which would also give you a sideroblastic anemia. Okay, the second characteristic of the tongue we look at is the color. What is the color of your tongue? If it's a pale tongue, you're thinking about anemia, right? Especially appreciated on the undersurface of the tongue, the same place we look for jaundice. If it's yellow, jaundice mainly on the undersurface, thank you. If it's a bluish tinge, it could indicate central cyanosis, but also in states of self-hemoglobinemia and methemoglobinemia. Right? Sorry about the typo here, but if it's bluish red, it could be polycythemia. If it's a black tongue, you're thinking about something called linea nigra, which also can happen with ingestion of bismuth, licorice, and charcoal. Addison's disease as well gives you this, where we have hyperpigmentation of certain parts of the body, notably the undersurface of the tongue, notably the palmar creases and so forth. If it's brownish discoloration of the tongue, you're thinking about chronic kidney disease. If it's magenta colored, you're thinking, okay, riboflavin deficiency. If it's a raw, beefy tongue, you're thinking about vitamin B12 or niacin deficiency. The situation is pellagra, where we talk about the infamous Ds, okay, which is dementia, diarrhea, dermatitis, and death. If you have white patches over the tongue, like what was depicted in our case, you're thinking, okay, is this candidiasis or leukoplakia? Alrighty. So here, thank you once again to short cases in clinical medicine. You see a smooth, pale tongue, which is kind of atrophic. Here we see a fissured tongue. Here there's oral candidiasis. And how you will distinguish candidiasis from oral hairy leukoplakia is that leukoplakia happens on the lateral surface of the tongue. Candidiasis, not really. And if you take a little wooden spatula and scrape off the lesion, candida will come off, maybe with some bleeding, but leukoplakia does not. Oral candidiasis is due to a fungal infection, but leukoplakia is associated with Epstein-Barr virus. Both are associated with HIV. And remember, EBV also can predispose to lymphoma. This is a black hairy tongue, something we call linea nigra. This is a geographical tongue, which rarely ever has any clinical significance. This is a black tongue, right? Once again, linea nigra. Here we can see gum hypertrophy with oral candidiasis. And there's a big differential for gum hypertrophy, right? Including phenitwine, acute myelomonocytic leukemia, among others. This is the raw beefy tongue, which may speak to B12 deficiency, riboflavin deficiency. Okay, the list goes on. Color of the tongue. If it's a black hairy tongue, it could be due to smoking or fungal infection and antibiotics, thinking tetracycline, penicillins. If it's a furred tongue with a grayish coating, you're thinking about smoking or chronic illness. A strawberry tongue speaks to scarlet fever. A geographic tongue is what we've seen, which looks like a map almost and rarely ever has any clinical significance, but may indicate riboflavin deficiency. If it's a glossitic or a so-called ball tongue, you're thinking about B12 or iron deficiency. celiac disease, pellagra, or tropical spree. The third characteristic in the tongue, guys, is are there any masses or ulcers present on the tongue? So ulcers we can subgroup or sub-stratify into being aphthous, malignant, tuberculous, Crohn's associated, or even snail tract ulcers in the setting of secondary syphilis. If there's a bite mark, especially on the lateral aspect of the tongue, you're thinking, okay, maybe this patient did have a convulsion before and they bit their tongue. If there's a growth in the tongue, you're always suspicious of squamous cell carcinoma. Squamous cell carcinoma. Hairy leukoplakia, we said, painless, whitish, corrugated on the lateral aspect of the tongue associated with EBV in the setting of AIDS. Papilloma in the mouth in the form of viral wart. Cyst in the floor of the mouth is a ranula, and you want to contact your ENT for excision. Next characteristic is the size and shape of the tongue. Macroglossia simply means big tongue, right? And there are many differentials for this. It can be Down syndrome, it can be acromegaly, cretinism with hypothyroidism, myxedema, primary amyloidosis, mucopolysaccharidosis like Hunter's Hurler syndrome, and tumor infiltration as well. Macroglossia has a small tongue, and it happens especially in the setting of bulbar or pseudobulbar palsies. Right? So bulbar speaks to a lower motor neuron lesion, right, of the 9th, 10th, and 11th, as well as the 12th nerve, and pseudobulbar is an upper motor neuron lesion of the same. Or it could be a lower motor neuron lesion of the 12th nerve, where the tongue is kind of weak and it's atrophic. So looking at neurological disease, which is the fifth characteristic, if the tongue is flaccid and wasted with fasciculations, thinking about bulbar palsy. If it's a spastic tongue without fasciculation, you're thinking about pseudobulbar palsy. Right? In rheumatic chorea, you have the so-called jack-in-the-box sign when the tongue darts in and out of the mouth. In tremor of the tongue, you think about anxiety, neurosis, thyrotoxicosis, chronic alcoholism, as well as Parkinsonism. If there's deviation of the tongue to the opposite side, you're thinking about an upper motor neuron lesion of the 12th nerve. But if it's deviation to the same side, you're thinking about a lower motor neuron lesion of the 12th. But how do you know by looking at the tongue whether it's upper or lower motor neuron? Aha, if it's flaccid, with fasciculations, thinking about a lower motor neuron lesion, which is a bulbar palsy. If it's a spastic tongue, it's deviated to the opposite side without fasciculation. That's a pseudobulbar palsy. Got it? If there's loss of taste sensation, especially the anterior 2/3 in a facial nerve palsy and posterior 1/3 in the glossopharyngeal nerve palsy. Fasciculation speaks to a bulbar palsy of the 12th nerve. They have a so-called chewing tongue in atothosis. So once again, thank you. Short cases. Macroglossia, we can see here, it's a big tongue. Here's Stevens-Johnson syndrome with a typical lesion which also involves the mucosa. Here's oral lichen planus, we can appreciate. Here is the hemangioma. Alrighty. So what are the causes of mouth ulcer? Mouth ulcer may seem as if it's a trivial problem. Sometimes it could herald serious disease. Right? So it could be an aphthous ulcer, which is usually idiopathic. Right? It could be due to a trauma, or could indicate GI disease like Crohn's and celiac disease. Could be an indicator for rheumatological diseases, especially Behçet's syndrome or systemic lupus erythematosus or Reiter's syndrome. Local infection can give you mouth ulcers, the likes of viral, and then we have herpes simplex type 1. Right? So it's herpes labialis. Herpes genitalis occurs in the genital area and is caused by HSV2. Syphilis in the way of a chancre, if it's primary syphilis, or a snail tract ulcer and secondary syphilis. Don't forget TB and Vincent's angina. Mouth ulcers also happen in the setting of Stevens-Johnson, like we've seen, or pemphigus vulgaris or pemphigoid, erosive lichen planus, cytotoxic drugs. That was a mouthful. What are the features of oral cancer? So when will you think that this lesion in this mouth looks, quite sinister? If there's a single irregular ulcer without local trauma, or if there's a single white patch, something we call leukoplakia, if there's a single red patch, a fixed mass which is hard and irregular, together with accompanying cervical lymphadenopathy. What are the causes of halitosis? Whew, that breath smells bad. Yuck. Right? It could be due to poor oral hygiene, fetohepaticus, right, which is due to methyl mercaptan accumulation in hepatic precoma. It's a sign of liver failure. Acetone breath we have in diabetic ketoacidosis. Some people describe it as a fruity odor. If there's a fishy kind of ammoniacal odor, you're thinking about renal failure. And others like smoking, alcoholism, lung abscess, which is fetid, and once you smell it, you'll never forget it. Man, that thing stinks. And Zenker's diverticulum as well, right? What are the causes of gum hypertrophy? We mentioned a few. So pregnancy, drugs, and more drugs. Phenytoin, nifedipine, cyclosporin, oral contraceptive pill with a high estrogen content. Don't forget acute leukemia, especially like we said, the myelomonocytic flavor. gingivitis and scurvy. Okay, guys, back to our clinical case. We had a 58-year-old gentleman, known with hyperlipidemia and hypertension, controlled with atorvastatin enalapril, smokes. We see some ulcers in his mouth, which we had shown before, and the answer there was oral leukoplakia. And the clue to the diagnosis is that he had a painless mouth ulcer. And ulceration, as we know, is the most common mucosal lesion, and the vast majority of acute ulcers are painful and self-limited. Of major concern, however, are the chronic, relatively painless ulcers. So if you have a painless ulcer, that's a red flag, together with mixed red-white patches, which is erythroplakia and leukoplakia, of greater than 2 weeks duration. Then, my friend, you got to start worrying. Guys, we're speaking about the tongue, and the tongue can be used to speak words. Sometimes those words are lies. So we're talking about lies today. What does the Bible have to say about lies? In the book of Ephesians chapter 4 verse 25, Paul says, "Therefore each of you must put off falsehood and speak truthfully to your neighbor, for we are all members of one body." Hallelujah. Revelation 21 verse 8 says, "But the cowardly, the unbelieving, the vile, the murderers, the sexually immoral, those who practice magic arts, the idolaters, and all liars, they will be sent to the fiery lake of burning sulfur." This is the second death. Beloved, I pray that we will pursue truth and holiness and depart from speaking lies. Even white lies, let us depart and desist from that. Here are my references. God bless you. I'll see you soon with another video on this channel. God bless you.